So our case number 2 involved a perimenopausal female presenting with obstructive CAD on the cardiac CTA. So our patient is Maria. She's a 49-year-old Latina female who originally presented to her primary care physician with complaints of intermittent left-sided chest pain. It all started at age 17 when her mother originally died from breast cancer at the age of 40. At that time, it was felt to be stress-induced. However, recently her symptoms have become more intense. She has a known history of generalized anxiety, white coat hypertension, diet-controlled hyperlipidemia, GI issues, GERD, irritable bowel syndrome, asthma, and family history of presumed premature cardiovascular disease in her maternal grandfather. She had 3 pregnancies with no adverse outcomes, no toxic habits. She is perimenopausal, currently taking hormonal therapy for hot flashes and libido. She exercises 4 to 5 times a week, and she leads a healthy diet. I want to start with Dr. Parapid. First, about the white coat syndrome or white coat hypertension. What do you think about it? Is something that is benign simply because we're rushing the patient into the room, they're being nervous, being and their physician, anxious about their stress test results, or it is something that we have to pay attention more to it and it has long-term consequences on the cardiovascular risk?
Thank you, Dr. Nseir. Well, so we know that white coat hypertension actually and mask hypertension are risk factors in the long-term follow-up because women tend to develop both diabetes, carotid artery stenosis, and they're also linked to CKD. So in this particular case, she was someone who should have been treated for at least with dietary management, although her current dietary management is fine, we cannot say it. On the other side, she also has anxiety, as you have mentioned, and we know that mental stress and everything that is described under the mind-heart axis is a risk factor for coronary artery disease.
Regarding her hormonal therapy, Dr. Parapid, how do you incorporate this in the risk factor of a woman? And if somebody has a CAD or no known CAD, does it make a difference in your recommendations?
Well, we know now that actually, although hormone replacement therapy is something that we accept as management of menopause and menopausal symptoms, it is not something we advise neither for primary nor secondary prevention of cardiovascular disease. And according to both her study and Women's Health Initiative, we only tested basically oral versions of estrogen with some progestin, and they tend to have a higher risk for developing thromboembolic events. So if we eventually need to opt for something that is hormone replacement therapy, I think that Dr. Rubinstein would agree also with me that we would opt something that would be patches and estrogen only, but sadly we don't have RCTs for that, for a long-term follow-up. So they surely have played a role, but with her background and her history, family history, I think that even without that, it could possibly be something that was somehow doomed to happen.
Thank you.
Thank you.
So Maria goes to the cardiologist, and EKG was performed that showed non-specific ST changes. She was referred for an echocardiogram and treadmill nuclear stress test. The echocardiogram was basically benign, ejection fraction of 60%, no significant valvular heart disease. The treadmill nuclear stress test showed it was non-ischemic. The EKG portion was non-ischemic. She had a very good functional capacity, reaching 12.8 METs, and normal perfusion at rest and stress, and normal LV function at peak exercise. Dr. Bellamkonda, what are your thoughts? You spoke earlier about anatomical versus functional testing. What are your thoughts specifically in premenopausal women? And what would you recommend? What would you prefer? And how would you interpret Maria results in this context?
Yeah, so she walked close to 12 minutes on the treadmill and with high meds. So that's reassuring. I think that's good prognostication, because the more you exercise, that says in case in future you have an MI, you're going to do better compared to poor outcomes. So I think I keep answering this question, functional versus anatomic testing. With her risk, if she's ASCVD risk, low to intermediate, then I would go for anatomic testing, especially if she's so active, she's, dancing, 4 times a week, things like that. She probably is going to perform well on a treadmill stress test. So.
Okay. And Dr. Sraow, Dr. Mamas, do you have a different opinion being interventionist?
Yeah, based on what was done thus far, I really wouldn't feel inclined to do much more except for reassurance. Like Dr. Bellamkonda mentioned, she had excellent performance on her treadmill, and her echocardiogram shows that she has a good function. So thus far, with her exercise capacity and her capabilities, I would just reassure and continue to monitor. I'm not sure if Dr. Mamas has a different opinion.
Yes. So in the UK, we don't generally do ischemic testing as first line. We would always do anatomical testing. So cardiac CT is our first line. So in this case, I wouldn't do a functional test. I would go straight for cardiac CT.
Okay. So Maria, based on her stress test, Maria was reassured and she was told that her testing was normal. She was suggested to follow up if her symptoms remained ongoing. Almost a year passed by, and most recently, she started having increase in the intensity of her symptoms. She returns to the cardiologist, and at that time, a CTA, a cardiac CTA, was ordered. So again, Dr. Parapid, do you think cardiac CTA was appropriate at this time? Since a year has passed, would you have said, let's repeat the stress test, cardiac CTA, or the cardiac CTA results, probably we should do straight for coronary angiogram, she's still having chest pain?
I think that also we're living in the era of shared decision-making, I believe. And since, even in the corners of the world where you least expect it. So our patients take, as you have mentioned, they read a lot of different things, and sometimes they come with their own management plan when they come to see us. So to compare with what Dr. Mama said, they would do a CTA in UK. She most likely wouldn't get a CTA in Serbia or somewhere in Southeastern Europe, because we had more developed stress echo imaging techniques, and we love to stress echo people. And a group of us who are fans of nuke studies send them for nuke studies just because they're the higher sensitivity and specificity. I think that we would all agree, even from a cardiac surgeon point of view, it's a better option than to have them run the treadmill. But I don't think that her CTA could be any better like a year later. So frankly, I don't know what that would bring to the table in terms of what would be new. And on the other side, there's also a possibility that besides macrovascular disease, she most likely has also a microvascular disease. And in that case, nothing what we have offered here on the options that we discussed is then the solution.
Okay, thank you. Dr. Sraow, do you think coronary angiogram, being also again an intervention, would have been inappropriate? Her symptoms kind of are on the atypical side. She had a very good stress test 9 months ago.
Yeah, I think that my pretest probability in this case would not be high. So to go straight for invasive angiography would be, in my opinion, aggressive. I think CT angiography would provide good information, especially if we found something that was borderline the utilization of CT-FFR, which we can get anatomical and also functional information. But I personally think that CT angio-invasive would be too aggressive.
That's the way to go. So this is her cardiac CTA. The slide on the left, it's the LAD, the left anterior descending artery. She had some moderate disease and mostly non-calcified, 50 to 70%. The left circumflex is not shown, but she had diffuse luminal irregularities. On the right side is the RCA. She had multiple focal lesion ranging between 60 to 70% with mixed plaque, again, moderately calcified. Dr.
Bellamkonda.
Pallavi.
Bellamkonda, yeah. So then Dr. Sraow spoke about the FFRCT. What is FFRCT and when is best used? Do you use it on every case or do you put it in a clinical context?
Yeah. So FFR, I think we know that a lot because from invasive cath lab, Dr. Naik and Dr. Sraow do it, FFR in the cath lab. But FFRCT, it uses computational fluid dynamics, and we use it in patients who have, anywhere between even above, so 50 to 80% stenosis in that gray area to see if it's actually functionally significant. So that's where we use it in those patients. Yeah.
So right now we're gonna go to the polling the audience. So what would you know next? Is it aggressive medical management and lifestyle modification? Suggest coronary angiography was possible intervention? FFRCT as explained by Dr. Bellamkonda? Or perform a functional testing again, another stress test to see if those lesions are significant? Okay. So 37% will suggest coronary angiography was possible intervention. Actually, they're still polling. 38%.
It's good. It's
Coronary
November. Everyone's
angiography was
voting. What do you
possible
want?
intervention. 48% FFRCT, and the minority that will go aggressive medical management with lifestyle modification, and another 10% perform another functional stress test. Dr. Mamas, as an interventionist, what would you do next?
Sorry, let me unmute myself first of all. So I guess FFRCT is a reasonable approach here. Generally in my unit, we would go for FFRCT. I mean, the forecast study that I was one of the co-investigators for, published recently, suggested that there isn't a health economic benefit to doing FFRCT, but certainly reduces the need for invasive cardiac catheterization by about 20%. So I think FFRCT is reasonable, but offer the patient diagnostic cardiac catheterization. Patients prefer that.
Okay, thank you. Okay, so Maria was suggested for coronary angiogram. In addition to this, she was suggested to initiate a plant predominant diet and start medications, including aspirin, high-intensity statin, long-acting nitroglycerin, beta blocker, and also she was advised to discontinue her hormonal therapy. After a long discussion, the patient agreed to lifestyle modification. She stopped her hormonal therapy. She started her medication, but she wanted to defer any further testing and invasive approach if possible. Dr. Parapid, can you please explain on the plant-based diet? And additionally, also, can you talk more about guideline-directed medical therapy? And what would you consider adding?
Okay, thank you. Well, to begin with, we all know that women are usually underprescribed everything that is guideline-derived medical therapy. So in her particular case, she got a beta blocker, she got a high-intensity statin, she got an aspirin. Something that is currently not in the guidelines, but we have latest evidence is that she could potentially, although she doesn't have a diabetes, but she does have cardiomyopathy. I mean, she has ischemic cardiomyopathy with such stenosis. She could get an SGLT2I inhibitor to preserve her LVF long-term. for instance. Okay, and this is the trained diabetologist in me speaking, not just trained cardiologist, but that is also an option. And besides, getting her to full plant-based diet would be something that would long-term improve all her outcomes, as we know well. And the other question is, of course, she's her heritage and her habits of organizing her own household would then also be influenced, which is good for the rest of the family as well, but not to be hostages of our own cultures, as some colleagues say. But I think it could be also an option.
Okay, thank you. So before we proceed with Maria's case, I want to talk about a trial that's recent called the Ischemia Trial that changed our management in treating patients with stable ischemic heart disease, meaning they didn't have any acute coronary syndrome, angina at rest, or MIs. So previously, stable ischemic heart disease, we didn't know if coronary vascularization changes the prognosis of the individual, most importantly, mortality. So the Ischemia Trial, they randomized almost 5,000 patients. They randomized them to, they did stress tests if they had moderate to severe ischemia. They got coronary CTA. If they have obstructive CAD, they randomized them either to conservative therapy or take them to the cath lab with the intent of revascularization. And they followed them over 3 years. The mean age was 64-year-old, and the percentage of women that were involved was 23%, and 41% of the study cohort had diabetes. So, Dr. Mamas, can you please tell us about the rationale and the background of the Ischemia Trial, and how does it compare to previous trial, the Courage Trial, FAME2, and Barry 2D?
Okay, so I guess taking a step back, the Courage Trial was a randomized control trial where they screened 38,000 patients, and the inclusion criteria were patients with one or more coronary lesions that were felt to be significant. Of course, left mains were excluded, and the patients were randomized to medical versus PCI arm, 2,400 of the 38,000 screened. There was no significant difference in MACE between the two cohorts, but interestingly, what they observed was that there was an increase in risk associated with increasing ischemic burden. So the idea was that if you found patients with a high ischemic burden, would intervening on them impact on outcomes? That was the raison d'etre for the Ischemia Trial. The Barry 2D trial was a cohort of diabetic patients, 2,300 patients, and it was a randomization of patients into number one, revascularization versus medical therapy, and number two, insulin sensitizing versus insulin promoting therapies. And what that showed, again, was that for the revascularization arm, there was no difference in death, no difference in MACE. Interestingly, however, in the Barry 2D, for CABG, there was a prognostic impact in terms of MACE, mainly driven by recurrent myocardial infarction, but not death. And finally, there was other trials, such as the RITA trial, and again, that showed no benefit of PCI, or the RITA 2 trial, no benefit of PCI over medical management. Now, the really important thing to bear in mind for all of these trials, often people think about them in terms of PCI versus medical management, and that's not the case. What we find out from these trials is that the vast majority of, or a significant proportion of the medically managed patients end up getting revascularization as well. So for example, in the Barry 2D trial, 15% of the control arm at 2 years had revascularization. It increased by about a couple of percent every year. So by the end of the 4 years, something like 40% of medically managed patients had been revascularized. In the Courage arm, 30% of patients at 5-year, RITA 2D, 40%. And so really what the trials are looking at are upfront PCI versus medical management, where a lot of patients do end up having to cross over and get revascularization. But certainly from the Courage trial, we have data now up to 15 years showing no mortality difference between the medically managed and the invasively managed cohort of patients.
Thank you. Dr. Parapid, just going into the demographics of the trial, and this is the theme of the day. So 64% of the cohort was the white population, 5% Black, 14% Hispanic, 31% Asian, and less than 1% Native Indian. Can you give us quickly your thought on that? Is it seen in different studies, and how can we change that? I know that has been a recurring question.
Yeah, but basically, if we look at our guidelines today, they are made basically for white men, because the studies that were included for our guidelines and the ones based on which we made our decisions for the guidelines have majority the population that is not the population that mimics the demographics in the majority of our countries worldwide. So in order to actually get something that is more accurate to the patient population we see every day, we have to change our recruitment practices. And I think that also, of course, that there are plenty of publications that have appeared actually in the past year and a half, dedicated to different different portions of our trials and different diagnoses that we were investigated. But sadly, every single time there was a very low percentage of women included in all our trials. And if we look at all the late breakers that happened in 2019 and 2020, there is basically, I don't know, 2 trials maybe that had 50 or 60% of women. And that is something that is definitely something that needs to change if we want our guidelines and our practices to be dedicated to the populations that we see in our clinics.
Thank you.
Thank you.
So like Dr. Mama said, these are the results of the Ischemia trial, basically the composite endpoint of death due to cardiovascular causes or non-fatal or MI. They were similar at 6 months and 5 years. However, there was an important finding in Ischemia trial. The quality of life was better with revascularization. And 50% of those who were treated invasively, they were angina-free after 1 year versus 20% who were treated conservatively. Dr. Mamas and Dr. Sraow, again, based on the improvement of the quality of life, and again, I will ask you again, did the Ischemia trial change your practice? Or if it didn't change your practice, did it change your way you present revascularization to the patient?
In my case, definitely yes. Basically, doing any sort of ad hoc PCI for me is out. Only in the case of acute coronary syndrome, of course, it would be. And a trial of anti-anginals is appropriate in almost everyone. And like Dr. Mama said, the crossover was quite high, so that I anticipate what happened in real life as well. To jump in and put in a stent, you cannot undo that, but you can wait. And if they have stable angina and their quality, if it's significantly affecting their quality of life at a later time, you could always revascularize. So it has really pushed me towards at least trying to aggressively avoid percutaneous intervention.
Dr. Mamas, in UK, ad hoc or non-ad hoc PCI?
So it's definitely changed my practice. Certainly the Courage nuclear sub-study suggested much worse outcomes in patients with more than 10% ischemia. And so my practice before the ischemia trial was to revascularize these patients. I think what ischemia trial has shown us is, yes, these patients may be at high risk, but revascularizing them does not give them any better outcomes. So patients will not get into my cath lab table unless they are on anti-anginals. Now, the question, of course, is whether lifestyle impacts on patients taking anti-anginals, such as beta blockers and so forth. And it may be that patients would rather not take so many medications and would rather have percutaneous coronary intervention. But then I do say to them that, I'm not doing this for any prognostic reason. This is purely symptom-based. I don't do ad hoc PCI. Before patients come onto my cath lab table, they would usually have a cardiac CT and a CT-FFR and would be on a number of anti-anginals in the elective setting.
Thank you. So again, Dr. Bellamkonda and Dr. Parapid, regarding the quality of life, do you think a role for the cardiac rehab? Also, since in the Ischemia Trial showed that there is increase in spontaneous MI in the conservative arm, can you touch a little bit about the LDL goal in the ACC and the European Society guidelines? What's the LDL goal?
I can go first. So according to ACC, the LDL goal is going to be 70 or lower, or based on the starting presentation of the LDL, 50% reduction. But the ESC guidelines are much more stricter, so it's 55 or lower. So I think there is a little bit of discrepancy, but lower the better LDL. Dr.
Parapid, any comments on cardiac rehab?
I think that first I echo Dr. Bellamkonda's thoughts. Definitely, it had the lower the better, if possible. But definitely, women are also under prescribed cardiac rehab, and I don't think any one of us had a patient who was a woman who ever had any event or was revascularized in any way who didn't immediately ask, can she return back to whatever is her daily normal routine. So I think that even for educational purposes of teaching these women to slow down in their everyday life, because one recovery is, as Dr. Brady mentioned, and Dr. Mamas also didn't want to have a cabbage, so like no one of us wouldn't want to have a cabbage. It's very difficult for our patients, especially when you offer them a PCI, to understand that actually their recovery might take as much as it would take with a cabbage. So that is, at least for multiculturally, women tend to return to their full agendas as soon as they're back home. So I think that at least for teaching purposes of slowing down, it is good to prescribe them rehab, irrelevant of the outcomes that we know are long-term better with follow-up treatment and rehab.
Okay, thank you. I'm gonna skip the poll again. So after shared decision-making, aggressive medical management was suggested. Maria had side effects to long-acting nitrate and beta blockers. She was tried on amlodipine also. That was led to side effects and recurrent headaches. Finally, she was referred to cardiac rehab, but she declined. Eventually, Ranexa was started with the resolution of her symptoms. Her lipid panel after 6 weeks of high-intensity statin showed a total cholesterol of 123, triglyceride of 57, LDL of 57. So the top 5 take-home messages: among patients with stable chest pain, the use of diagnostic testing should be based on structured assessment of cardiac risk and targeted to patients who most likely benefit. It's important to understand the benefit of using anatomical versus functional testing. The use of coronary angiography and subsequently intervention with stable angina does not impact MACE events, but it can improve the quality of life. Medical therapy and lifestyle modification should be aggressive, and shared decision-making is important.